Hi, everyone. We're going to wait 1 or 2 more minutes for more people to join in, and then we'll be starting. Hi, everyone. This is Sarah Martin, the Community of Practice moderator, and I wanted to welcome you all to this great webinar on feminist approaches to mental health and psychosocial support in emergencies. Let me tell you, for those of you who aren't familiar, I work for the GBV AoR, which is the Global Working Group on Gender-Based Violence in Emergencies. And I'm one of the co-moderators of the Gender-Based Violence Community of Practice. We're over 750 GBV specialists from around the world. And at the end of the webinar, we'll give you a little more information on how you can join if you're interested. And this is a joint webinar that we're doing alongside the GBViE Helpdesk. So I'll turn it over to Laura to say a few words about the Helpdesk.
That's great. Thank you so much, Sarah. Yes, I'm Laura, and I manage the GBV AoR Helpdesk, which is a unique research and technical advice service for a range of humanitarian actors working to prevent and respond to GBV in emergencies. And we're a free and confidential service which is available to staff from UN agencies, international charitable organisations, and women-led organisations and groups working on the front line to, as I said, prevent, respond and mitigate gender-based violence in emergencies. So at the end of the webinar today, we'll give you a bit more information about how you can access the GBV AoR Helpdesk and how we might be able to support you. But in the meantime, I'll hand you back over to Sarah.
Thanks so much, Laura. So now I have the great pleasure to introduce Jeanne Ward, who's going to be facilitating this webinar and who is the author of the Helpdesk briefing note, which is what we're going to be presenting today and speaking about. Jeanne, over to you. Jeanne?
Sorry, I didn't unmute myself. Okay, bad lesson. You would think I would know this working in Zoom so much these days. Just want to say thank you, Sarah. Thanks for all the work you did pulling this together. Thank you, Laura, and the Helpdesk for all your support as well. So just looking at this slide, just to give you a little bit of an overview of what we plan to do today, I'm going to introduce you to the learning brief that I drafted on feminist approaches to specialized mental health care for survivors. This is available on the GBV AoR website. I'm not going to spend a lot of time on it because hopefully if you haven't read it already, you'll be interested to kind of look into it after the webinar is finished. I really want us to spend more time in this webinar learning from experts in the field. And partly this is because there isn't a lot of, as we'll discuss, there isn't a lot of information about what's being done in the field to apply feminist approaches to mental health and psychosocial support programming. And yet I know there are there's so much important work going on. So this is really an opportunity for us to kind of expand on the learning brief by taking the opportunity to speak with experts about how they're using feminist approaches in their mental health and psychosocial work. So these experts, I'm going to introduce you again to them after I present the learning brief, but just now, if I can just ask you all to come on to your videos so you can say hi to people. We have Nasanat from Raising Voices. She's the Violence Against Women Prevention Coordinator from Raising Voices in Uganda. We have Caroline, who's the Director of Medica Liberia, and Sahar, who is a consultant with IMC in the MENA region. We're so lucky to have you. Thank you for taking this time to be with us and to share your expertise. Okay, so again, we'll hear from them in just a minute, but let me just kind of jump in now to the learning brief. So the learning brief, as we've already mentioned, is a product of the GBV AoR Helpdesk. These products are a result of requests that come in from people like you for information. And the great thing, I just want to plug this for those of you who are just coming onto the call now, is that you can send a request into the help desk, and there are a roster of GBV experts who are on standby to try and address your request. And it's a free service provided by the AoR. So we got a request about feminist approaches to specialize mental health. So we'll talk about that in just a minute. The request was seeking to address the questions of what are the basic tenets of a feminist approach to specialized mental health care for survivors of GBV, and what's the evidence for this approach in humanitarian settings. So I kind of dug into the research on this, and there was a real absence of literature, as I've mentioned, from humanitarian settings. Most of the literature that underpins the learning brief comes from high-income countries. There is, I think, some academic literature out there about interventions that are happening in humanitarian settings, but it was really important for me as the author of the learning brief, and it's kind of a practice of the help desk in general, to try and draw from resources that readers can actually access, rather than some of the academic resources that are behind walls that cost money to access. So I was really trying to find sources that you all could use. I was trying to reference sources that you all could use. So that in some way also determined sort of the scope of the learning brief. So the learning brief discusses GBV and mental health impacts. It identifies the three-tiered approach to psychosocial and mental health responses in emergencies. And then it seeks to define feminist-informed therapeutic treatment and reviews principles and approaches related to feminist-informed therapeutic treatment. I just want to say, though, before we get into this, into what we're looking at in terms of mental health and psychosocial support, that the lack of evidence of applying sort of feminist principles and approaches in humanitarian settings doesn't mean that it isn't already being done. And I've seen a lot of, I recognize a lot of the names of people who've joined this webinar, and I just want to really emphasize the important work that I know that you're already doing to try and apply feminist approaches to your mental health and psychosocial support work. mean, in one sort of broad example, the survivor-centered approach, so where those who provide GBV-related services prioritize the rights and needs and wishes of the survivor, that reflects and reinforces some of the foundational principles of a feminist-informed approach, as you'll see as we move forward. So thank you, everyone who's joined us, for all the work that you're already doing to try and apply these principles. And we'll learn more from our panelists about how that's actually being done in humanitarian settings. So just a brief look at mental health care in humanitarian settings. The humanitarian community has strongly endorsed the importance of mental health and psychosocial support interventions in humanitarian emergencies. We have the GBV case management guidelines, we have the interagency GBV minimum standards, and we have additional IASC guidelines on mental health and psychosocial support. So the GBViE minimum standards have adopted the ISC's tiered approach to care. Nope, sorry, back. I just want to go through the tiers so we understand what this particular learning brief is focusing on. The minimum standards have adopted the ISC's tiered approach to care and support that's outlined in the ISC mental health and psychosocial support guidance, and adapted it to providing support to GBV survivors. And you can see that in this figure. In this adapted model, the majority of interventions are concentrated in building community supports and in providing focused, non-specialized care through, for example, psychological first aid and psychosocial support and women-friendly spaces. And it links to relevant guidance within the standards themselves. Although these are the dominant approaches, the tiered model recognizes that specialized services for the provision of mental health care to affected individuals must also be available. However, so that's kind of layer 4 of specialized services. Despite the recognized need, specialized mental health interventions for sexual violence and for other forms of interpersonal GBV are limited in humanitarian settings, and the evidence of good practice is even more limited. Okay, so let's go now, next slide, Laura, please. Let's look at what we mean when we talk about feminist-informed approaches to mental health care. Feminist therapies were informed and grew out of the feminist movement in Europe and the US in the 1960s. Feminists were critical of traditional approaches to mental health that applied a medical model of treatment, one that emphasized dysfunction of the person with the mental health condition, and often treated mental health issues as a physical disease that could be resolved with medication. Feminist therapies sought to develop a theory and practice that recognize social and cultural causes in understanding and treating psychological distress. Feminist therapies can help survivors to recognize that their mental health issues are not only related to internal mental health problems or even exposure to a specific event or incident of violence, but rather to a pervasive culture of violence against women that patriarchy reflects and reinforces. One goal of feminist therapy is to support improved awareness of these external influences, so as to improve understanding of the social factors influencing the personal experience of the woman receiving mental health care. Evidence suggests that feminist-informed approaches, and this is really important, are useful in mental health interventions with all women, not only those who are survivors of sexual violence or other forms of interpersonal GBV. Also, feminist approaches can be utilized alongside other mental health interventions to generate better treatment outcomes. There's been research on this. So this is some of the evidence that's emerging from the research primarily in high-income countries. So recognizing and integrating the feminist value of equal rights for women into any treatment process including those treatments that focus more traditionally on change in the internal cognitions of a client, or the way that a person's own thoughts and beliefs and attitudes inform their mental distress, has been shown to have a positive impact. So if we take this a step further, recognizing explicitly during the therapy process of the need for change on external or systemic targets, so things like social relationships, institutional systems, and structures of patriarchy, can result in even greater mental health benefit for women in treatment. Now, a lot of the evidence focuses on treatment of females who've been sexually assaulted, and if we turn to that evidence, it suggests that contextualizing distress by situating it within the larger patriarchal social context of violence against women is critical to relieving survivors' sense of guilt and disempowerment associated with the violence, which can persist even after the stress symptoms have subsided through other types of treatment. Okay, next slide, please. So, as I mentioned, I tried to draw from resources that were available for, that could be accessed by the reader. And I came across one book, Feminist Perspectives in Therapy, Empowering Diverse Women, whose authors try and synthesize diverse strands of feminist theory to create what they refer to as empowerment feminist therapy model. The model integrates both feminist and multicultural perspectives. It's an entire book that's downloadable and includes a review of the foundations of feminist therapy, while also emphasizing the importance of multicultural therapy approaches in order to avoid feminism that is white and Western centric. They detail 8 tenets of feminist psychology, which underpin all of the approaches outlined in their book, and which they suggest form the foundational principles of feminist-informed therapy. In this, you'll see they use we. You can see on the screen they use we. Their use of this first person we reflects the principle of personal accountability of the mental health professional that is central to feminist-informed work. So in their 8 tenets, they say, we advocate inclusiveness. We acknowledge that the social impact of gender is experienced unequally and unfairly for women with diverse personal and social identities, including ethnicity and culture, sexual and affectional orientation, socioeconomic status, nationality, age, and physical characteristics. We advocate equality. We recognize that the politics of gender are reflected in lower social status and unequal access to valued resources for a majority of women in most societies. We seek new knowledge. We value and advocate increased understanding about the diversity of women's experience as it is framed by multiple personal and social identities. We attend to context. Women's lives are embedded in the social, economic, and political contexts of their lives and should not be studied in isolation. We acknowledge values. Personal and social values enter into all human enterprises. Education, science, practice, and social advocacy are never value-free. We advocate change. We are committed to action to accomplish social, economic, and political change toward establishing equal justice for all persons. We attend to process. Decision-making processes that affect personal and group outcomes should be consensual and consistent with feminist principles of mutual respect and honoring all voices. We expand psychological practice. We recognize that feminist principles can be applied to all professional activities in which we engage. Theory building, prevention, counseling and therapy, assessment, learning, curriculum development, research, supervision, leadership, etc. Okay, so what does this mean in practice? Before we turn it over to our panelists, let's just look at a few points about what this means in practice for those of us who are doing mental health and psychosocial work. First, it means attending to the diversity of women's personal and social identities. This involves promoting an examination of women's multiple identities, whether consciously experienced or not, to improve understanding of how social identity informs women's expectations and behaviors and their experiences of privilege or oppression. Here we have a quote by Jessica Horn, who's writing on behalf of the African Institute for Integrated Responses to Violence Against Women and HIV/AIDS about the importance of context. She says, "A pillar of transformative African feminist approaches is the acknowledgement and response to the structural power relations." Sorry, we lost the page. Yeah, okay, great. Of the structural power relations underpinning and perpetuating individual and collective distress. Understandings of trauma in Western psychology tend to be predicated on a privileged idea that the world is fair and just in the first place, and that the work of therapy is a work of returning an individual to a place of peace or happiness. Possible if it is worked on consistently enough and with the appropriate professional therapeutic guidance. For people born into war, economic marginalization, and the discriminatory norms of racism, sexism, homophobia, and xenophobia, the world itself is a stressor. This means, in turn, that activism is necessary to change the structural roots of distress, while individual or group therapies are engaged to build the capacity to manage or engage the effects of these structural stressors in everyday life. Some other points about what this means in practice, and I'm not going to go into detail about these in the interest of time, because I want to make sure we have sufficient time to really learn from our panelists. But I just encourage you, in the learning brief itself, there's more detail around what these points mean. So, point number 2, explicitly recognizing gender and oppression in the therapeutic work with the survivor and applying a consciousness-raising approach. So this is a translation of those 8 tenets or feminist principles into action. It also, action means encouraging an egalitarian or more equal relationship between the survivor and the mental health provider, rather than a relationship of expert and non-expert. Reconceptualizing ideas of social and personal power away from traditional patriarchal norms that validate male authority, privilege, and control, and instead ensuring a woman valuing and self-validating process. This principle, and I know so many of you are already applying it, focuses on a strengths-based approach in which the woman receiving treatment is encouraged to identify her own strengths and to develop or enhance her ability to value and nurture herself. We know often that survivors' self-loathing and sense of helplessness are rooted in shame that's linked to internalized societal victim-blaming myths. So the feminist mental health provider is or will be skilled in suggesting new ways of perceiving to bring about meaningful changes in self-perception for the survivor that are based on a real understanding of the patriarchal social context. Okay, so let's stop there with the learning brief and hear from our experts. So Nasnet, can I just ask you to put your video on if it's not already, so people can see you?
Hi.
Nasnet Gibran, we're so happy to have you here, is the Violence Against Women Prevention Coordinator at Raising Voices in Uganda. And prior to this, she worked on GBV and humanitarian response in East and West Africa and Southeast Asia. The foundation of Nasnet's work is applying a feminist approach. So Nasana, I'm going to ask you a couple of questions. I'm going to try and keep us to time, around 10 minutes for the questions, and then we'll move on to our other panelists. My first question for you is, why is it important to apply a feminist approach to work on violence against women and girls?
Thank you, Jeanne, for the nice introduction. And then I'm happy to see some familiar names in the list of participants. So I think when we talk about addressing violence against women, say it prevention and response, feminist lens or feminist approach is quite essential. Even going back in history and we look at the genesis of this work, we have to recognize this work was initiated and led by feminists. So the work that they have done has helped us to understand violence against women deeply and broadly. Feminist approach or feminist analysis really helps us to see where the core or the root of the issue is. Basically, it helps us to see the power imbalance between men and women is the issue that is sustaining the problem or violence against women. And we are also able to see through the feminist lens that the norms and structures, and as you said, Jeanne, the system that reinforces violence against women, which is patriarchy. And we can see how the norms and structures of our family, community, and society are maintaining the issue and ensuring the continuity of the issue. And then also feminist analysis has helped us to understand that violence against women is not an isolated issue. It's not something that happens once in a while, or it happens just like one in million kind of thing. We know the statistics. For women, for us, it's like a context. It's a situation that we live in. And it's something that we also experience like throughout our life in different stages of our life. And it's a context meaning that something happens to a woman really make me think about my safety and my security. And it's the reality that we are living in. Feminist analysis has also helped us to understand that women are not homogeneous. Women in different places, even in the same context, have different ways of experiencing violence. So it really helps us and it challenges us to also have this thorough analysis of the issue. So as I mentioned, it's a way of analyzing and understanding the issue really well. Understanding a problem or an issue is a halfway to a solution. So if we have like a solid ground in terms of understanding and defining the issue, we are in a stronger position to design, implement, and assess the work we do to address violence against women. So what does that mean in action? We could use like various techniques and strategies, but they all have to be geared towards transforming the harmful norms, the structures and systems that are reinforcing violence against women. And also, when we apply feminist lens, we ensure women and girls are at front and center of the work that we do. We ensure the work is led, if not minimum, women's and girls' voices is considered and informs the key decisions at different stages of the program. And then also in recognition that we are not homogeneous, we also get to apply intersectional lens in a way to address the various needs and realities of women and girls.
Thanks so much, Nasnat. I feel like this resonates with so much that's in the learning brief. It's nice to hear you articulate these kind of feminist principles and approaches. I wonder if you can share with us just briefly what you think some of the key challenges are to bringing a feminist approach to your work on violence against women and girls, because I know many of us have experienced challenges. It would be great to learn from you what some of the challenges you all are dealing with in your work.
I think it's a great question to recognize the challenges and then think about how we could possibly address it. But I would really love to mention that the things that I'm going to share are also something that we are observing from the experience of other groups, other organizations that we collaborate with. So it's also worth mentioning that from the time I have started working like an issue of violence against women, there are so many things, so many gains that we have been able to recognize. Like 10 years ago, there were very few organizations addressing violence against women, but now in 2020, or like the last few years, we have really seen a growing number and interest, and then also commitment towards addressing violence against women. But some of the opportunity or the gains are also coming with some challenges. Like for example, with the growing number of organizations, there is something that we are observing around predominance of international NGOs, which are basing or kind of diverting their work from feminist analysis and using less political approach to addressing violence against women. And we are also observing a big issue of less accountable or non-accountable practices to women and girls. Women and girls, both in the communities, as well as the movement of women's rights organization and broadly the movement. So there is a tendency of doing things without any consultation, any collaboration with women's rights organization or women in general, and also replicating the patriarchal systems and values within the work that we are doing. There is also an issue with all the predominance of INGOs and non-accountable practices. The history is being overshadowed, the history that women's rights organizations brought into this work. Their experience, their knowledge, their voices, and perspectives are getting less and less visibility, and they are almost being sidelined from the work that we are doing. Generally, the backlash against women's rights organization is coming in different forms and from different angles. And then we recognized for transformative work requires a long-term approach. And the programs that we observe tend to be short-term. Like we can't really change or establish equitable systems within 1 or 2 years. So there are different challenges that we are observing around violence against women work. So just to summarize, non-accountable practices, short-term approach to addressing the issue, NGOs, making like less political or using less political a lens to addressing violence against women, and then overshadowing or making women's rights voices and leadership invisible.
Thanks so much, Nasnat. Very interesting and insightful learning from your very own direct experience. Okay, now let's turn to Caroline Boa. Caroline, can I just ask you to put your video on? Caroline is the director of Medica Liberia, and she's the co-founder of the Liberia Feminist Forum. Caroline, I'm going to ask you a couple of questions. The first question is, how do you apply a feminist approach in your counseling work? What does this mean in the work that you do and the work that Medica Liberia does?
I was still unmuted. And it's saying that I think I sort of dropped out when you presented, but then I caught on with when Nasnat was presenting. I think for us at Medica Liberia, Medica Liberia is explicitly a feminist organization, so therefore we dedicate feminist principles to our work. Like all of you have mentioned, the survival-centered approach. So we do prioritize the needs of women and girls as we provide our counseling, to the extent that they, what we call them, they make the decision as to what course of actions to take, so that they are in charge and remain in control even through their healing process. What we do is to facilitate that process, even to the extent that if a woman makes a painful decision to return, unless it is life-threatening, we allow her to make that decision. We only like sort of provide a supportive environment to ensure that is happening. Secondly, we place the counseling within the broader context. Like Lashmi, I guess you may have also mentioned, we base our psychosocial interventions on feminist approach that recognizes the wider context of the empowerment of women. We know that counseling is not just about the individual, right? It also recognizes gender-based violence in terms of its function, that, you know, there's also the family dimension, the community, and how it impacts a woman or a girl. So this is the analysis that we integrate into the way that we work with women and girls who are affected by violence. And like Nasnat had mentioned, of course, women are not homogeneous. They do have different sort of issues that we do have to look at it from different perspectives. Again, our approach sort of recognizes a holistic services or holistic levels, which includes the psychosocial, the emotional, the social, cognitive, and spiritual. The way we do that is also to be holistic, so that we're looking at the the individual and direct levels, and also what the society and structural challenges that sort of impedes women's movement forward. We are very deliberate about the term psychosocial, instead of using trauma therapy or other medical terms, because we consider the situation of women and girls in need that is much more complex than the medical terms. So we do not use PTSD or depression. We also conceptualize women and girls' psychosocial well-being in a way that it relates, like I mentioned earlier, to their social relationships and the social political context that they are operating in. We know Liberia, for example, have had several decades of civil conflict. These do have a different impact on women and girls. So that, and then lastly, we also recognize trauma as being political. And we believe that violence against women is a human rights violation, and our approaches goes beyond just the individual level, identifying the direct impact on women, but also how do we address the underlying causes of these GBV issues.
Thank you, Caroline. It's really great to hear your perspective and how you're applying these feminist principles in your work. I wonder if you can share with us, just take a couple of minutes to share with us some examples of specific interventions that you use and how these interventions facilitate the empowerment of the women you work with.
So we apply what we call a trauma-sensitive approach to our GBV program. And this means that we're analyzing, recognizing the trauma impact on survivors. So within the broader context, those service providers that they are seeking services for, we do bring them on board in terms of capacity building through the trauma-sensitive approach, but also so for example, with the police, with the court systems, with health, we integrate it into our program so that they understand the trauma impact on survivors of GBV. And then secondly, our community-based structures, we do have support. We have women at community levels who sort of are the first responders within their communities. These women have been trained over the years on providing supportive counseling, but also understanding GBV issues, and they're able to respond at their level unless it involves a situation where it goes beyond their scope, and then they can refer them to our teams. Lastly, we are also aware of the re-traumatization of, on our staff, on our community structures that we work with. So we are very keen on organizing self-reflection and self-care for them so that they avoid burnout and re-traumatization.
Such an important point. I'm really glad that you raised that last point about the importance of self-care. Ever more important in these particularly challenging times. Thank you, Caroline. Now I'd like us to turn to Sahar Mala. Sahar, can I ask you to put your video on? So Sahar is a clinical psychologist and a GBV specialist with over 10 years of experience in humanitarian settings in different contexts. With GBV case management and psychosocial support as her primary focus, she recently started developing and piloting a women's empowerment counseling approach with IMC that can be used in GBV case management. So Sahar, can you tell us about the women's empowerment counseling approach that you're piloting with IMC?
Sure. Hi, Jeanne and everyone. Can you hear me well?
I can hear you perfectly, Sahar.
Okay. So yes, so IMC has recently decided to roll out a new approach for women empowerment counseling in our programs in Damascus, where we already have an integrated MHPSS and GBV programming. So the reason why we decided to pilot these counseling techniques is because a big number of survivors was showing signs of PTSD, depression, anxiety, and other mental health problems. And I joined Caroline in not labeling the mental health problem. But anyway, so that was the reality. And there was a big number of referrals to the psychiatrist. So in order to try and find an alternative for this trend, we decided to build the capacity of the caseworkers and the psychologists in offering a layer of PSS that is additional to the case management. So as we know, case management and the use of the survivor-centered approach already has many aspects of PSS. For example, the emotional support, the active listening, the use of healing statements, the compassionate care, the provision of a safe and empowering environment where the survivor can organize her thoughts, make plans, take decisions, and of course reach a variety of services that meet many of her needs. So all this is in itself very empowering. And for many survivors, this will contribute to improving the psychosocial well-being. However, for some survivors, this is not enough. So they will still need an additional layer of support. And psychotropic drugs is not always the solution, or it's not effective alone. Now, psychotherapies can be a good option. However, from what I've seen, and I think many of you would agree with me, usually the approach taken in psychotherapies is very generic. So there's a tendency to focus more on the mental health problem and less on the social and cultural story of violence. So these techniques came to build the capacities of both the psychologists and the caseworkers to look at the mental health problem from a more holistic way. And the techniques were designed from a very like a GBV angle. And I think this is in line with many of the principles that you just presented, Jeanne. So to give you a few examples, the techniques are designed in a way to help the survivor recognize her strength, realize her self-worth, work a lot on self-acceptance and non-judgment, practice gratitude, deal with difficult emotions and anxious thoughts, replace negative self-talk with more empowering messages that she can say to herself, reframe limiting beliefs that she might have about herself or about the world, and basically make plans for her future. So all this is inspired from two schools of thought, which are mindfulness and positive psychology. And what these two schools of thought have in common with the feminist approach is that they focus a lot on a strengths-based approach, and they focus a lot on non-judgment and compassionate care and non-labeling as well. So the techniques, they are designed in a way with a very different steps. It's very interactive. And it includes a lot of psychoeducation to basically try to discuss these topics with the survivor and also discuss it in the cultural setting. And they are designed in a way that anyone, any caseworker can use them. So some techniques are a little bit more complex, so they might be preserved to caseworkers with more experience in counseling or to the psychologist, but many other techniques are designed in a way that any caseworker can actually use them because they are very detailed and they have a user guide. And right now where we are at is that we just did 2 months ago, we did a training to 2 batches of caseworkers and psychologists in Damascus. And now we are at the implementation phase. So we are piloting the techniques, and I'm doing a supervision exercise, which will be ongoing for the next few months, based on which we will see which techniques are most useful and how we can adapt them to basically to support a bigger number of survivors.
Great, Sahar. It's so interesting to hear about this project. It's really exciting. I'm wondering, just in the couple minutes that we have remaining before we turn it over to participants to ask you all questions. I'm sure there are several people who are anxious to get more information from you all. Could you just take a few minutes, just a couple minutes, to give us some examples about the implementation of the techniques specifically in the cultural context of Syria?
Yes, so I will try to be as brief as possible. So when we talk about these topics of self-worth or strength assessment, it's very important to understand them in the cultural setting, because if we want to help the survivor build a positive self-image, it's important to start by looking at the role of women in the Middle East. So there's a tendency for women in the Middle East to perceive themselves as caretakers, where part of their identity is to make others happy, be it the parents, the husband, the children, the in-laws, or society in general. And this translates into beliefs where women tend to consider their own happiness and well-being as secondary, because they tend to put others first. Up until today, in many societies in the Middle East, it is expected from women to sacrifice and make compromises to always make sure the husband is happy, even if he's not treating her well. And this belief is transmitted from generation to generation. And most importantly, it is transmitted among women themselves. So, for example, it's normal to find a mother tell her married daughter that she should make compromises and sacrifice in order to always make sure her husband is happy, even if he's not treating her well, because she should, between brackets, keep her marriage together. So there is this kind of normalization of suffering. It's okay to suffer because this is part of your role as a woman. So this is where we wanted to start, and to look at this reality and try to question it and slowly change it. In the supervision work I'm doing with the caseworkers and the psychologists, they tell me that when they start to introduce topics such as self-love or self-compassion or self-worth, we are often faced by surprised reactions from the survivors, as if they didn't know that they have the right to take care of themselves. So in one example, the psychologist was doing a strength assessment exercise, which is one of the tools we introduced, where we take time to look at different aspects of the life of the survivor. For example, her achievements, her talents, her strengths, things that she's proud of, things that give her meaning, and how she can use it in her relationships and environment. So in one case, the survivor was a woman in her late 20s, and she was subjected to sexual abuse when she was a child by her older cousin, and then again in her early 20s by a colleague with whom she ended up being in an abusive relationship, and then she managed to leave. So when she came to the clinic, she had signs of depression and low self-esteem and a very negative self-image, and she couldn't identify any strength. Although she has a university degree, she has a good job, and she is the main breadwinner for her family, but she couldn't, she was taking everything she's doing for granted, as if it's normal to suffer, it's normal to make compromises, it's normal to always give. So the psychologist had to do a lot of work on self-compassion, and this goes beyond the individual level of self-perception. It tackles more like collective social norms, where the question is how much a woman should suffer and give and sacrifice in order to finally believe that she deserves happiness and well-being. Because from a very young age, women in the Middle East are told that they should look pretty, they should behave in a well-mannered way, they should respect their parents, they should preserve the honor of the family, they should make a good candidate for a wife. And then once they are married, they should respect the husband, please the in-laws, take care of the children. Basically, they should make sure everyone else is happy. And in this constant search for people-pleasing, no wonder many women lose connection with their true selves and can no longer realize their self-worth, because their identity as a person is often connected to the expectations of others, or the validation from others, or the approval of others. So this is why for us it's very important to work on this, to start our work there, because if we help women realize her self-worth, we can help her regain power from within. So this is, of course, only on the individual level, but there's a lot of other things to be done on more the social level. So by doing that, we can help the survivor get rid of this fear of not being good enough in the eyes of others. And also we can help her let go of the guilt associated with taking care of herself. So we tell her that she is worthy, she is important, she is strong, of course, using these techniques. And because she is worthy and strong, she can choose to take care of others and not the other way around. So it's not taking care of others that will give you worth. You are already worthy. And it's not taking care of others that will give you meaning. You have the right to find what gives you meaning and make choices accordingly without having to pay the price for it. So very quickly, to go back to our survivor, there was a lot of work done in this perspective, and she reached a point where after a few sessions, for her it was an aha moment, where she realized that she spent all her life trying to please others, and she decided that it's time for her to focus on herself and on what she really wants and connecting with her true self. And she said that now I feel more comfortable with myself.
Mm-hmm.
So this is in brief. I don't think I have more time, but just to say that the language you are using is very important, and the topics we choose to discuss with the survivor within the case management setting can also be life-changing, I would say. And we're still at the piloting phase. I'm hoping that in the next few months we will have a better idea of which tools are working and what needs to be adapted. And I just want to say that the caseworkers are also implementing the techniques. So it's not something only reserved to a therapist, to a psychotherapist.
Thanks so much, Sahar. It's really moving to hear the story of the woman that your work has really helped, and a life that's been changed by the approaches that you're using. It's all of you all are inspirational in the work that you do, Caroline and Nasna as well. So just a moment to say thank you. I want to now give us just a few minutes before we close out to have folks ask questions. You can raise your hand if you know how to use that function, and we can call on you if you, or you can write your question into the chat box. I'm seeing some requests, Sahar, for the materials that you all are developing. I wonder if you have a sense of, are those going to go public? When would they go public? Maybe that's the first question we can respond to. And other people, please, if you have specific questions as well for Nasna and Caroline, please feel free to put them into the chat or raise your hand.
Okay, Jeanne, maybe I can answer. I think we need a little bit more time before we decide, you know, what to publish, which techniques. But I'm really hoping that we will have them available soon. So as I said, we're still piloting, and we would like, you know, to take a few months just to see how effective the techniques are, and if we need to do any adaptation before sharing it publicly.
Okay, so a couple more months, it sounds like, at least.
Yes.
Okay, so maybe in the new year we can look for the resource.
Yes, I hope so.
Okay. Any questions from any other folks? Caroline, I have a question for you while we're seeing if other questions come in, which is, do you all use, do you, just as it sounds like Sahar and IMC are developing a kind of manual for the caseworkers, does MENA also have a similar kind of manual that articulates a feminist approach in their interventions?
Yes, we do. We have our women's empowerment manual. We deliberate to not call it psychosocial for some other reason, but we call it women's empowerment. It's online.
Okay, can I just ask you, Caroline, can you write into the chat box, because people are sharing information in the chat box.
Okay.
Can you write the link in the chat box if you don't mind? Okay,
I'll do that now.
Okay, great. So that is an immediate resource for those of you who are on the call that you can access, and one that I know has been, that Medica has kind of refined over time. And Sarah's saying we can share the links to the over the COP. Laura is saying that if you have any questions about, if you want to follow up with any of the presenters or the GBV Helpdesk in general, you can reach out to the GBV AoR through the GBV AoR Helpdesk email at inquiries@gbvie helpdesk.org.uk. And if you want to join the community of practice, you can send an email to the gbvcop@gmail.com. Marie, your question is, would you have a concept note or an overview of the key concepts to share? Do you mean Sahar's work with IMC? Okay, for Sahar. Okay. So, Sahar.
Yes.
Do you have a concept note or anything?
I'm not sure what we mean by concept note.
I think it's just a summary of the, it looks like Maria's just looking for a summary of what you're, of the work that you're doing.
So we don't have anything available to be shared at this stage, but we could look at, we were thinking maybe to have a small learning brief from the experience. So yeah, I can look at developing something like that and maybe sharing it, but I have to check also with IMC what is feasible at this stage. Because as I said, we just started to pilot. I'm sure that there will be a lot of things to be shared soon. Yeah, I can check with IMC what can be shared at this stage.
Sorry, I'm Laura from IMC.
Hi, Laura.
Sorry for the interruption, because she's talking about something, me and other colleagues are involved. So I'm the technical advisor for IMC Middle East. So Manuela, which is the program manager, she's also online, and Sahar worked a lot on this initiative, and I of course try to help as much as possible. So we were definitely considering having something to share, but we would really like first to test it, have some time of testing and get back feedback from our staff and of course from the survivors that have been engaged, to have some kind of results from the testing before actually being able to share something. So as Sahar saying, that will require a couple of months at least, and then at that point we will collect all the feedback, look at the material and everything we have used so far, adjust it if needed, and then make it a bit pretty for external sharing. And at that point, I think we can start to share things. But I really would, ask people to be patient for another couple of months, because I think so far the initiative has been great, but we still wanted to have the testing phase and keep it internally as long as we are testing it, and then make it available. So yeah, I think as we said, a couple of months for testing and then finalize it. So early next year, probably, as Sahar already said.
Okay. Super. I think we're coming to the end, although it looks like we have one question that Sarah posted from Emily saying, I'm hearing a lot of techniques like those used in ACT. In your opinions, has that been most promising in some of the piloting that has been done? I don't know if any of our presenters want to respond to this question quickly before we end our webinar today. Any thoughts? Emily, by ACT.
Hi, yes.
Emily, are you on?
Can you hear me?
Yes.
Yes, so I'm just wondering, because it sounds a lot like the acceptance commitment therapy, that particular type that I guess differs from conventional CBT. And I guess I'm wondering if, I know that there's increased usage now in the world of mental health of ACT techniques, and I'm just curious as to its application in this particular area, just because a lot of the I'm hearing techniques that are being discussed that are similar to those that are used in that particular type of therapeutic technique.
Yeah, maybe I can jump in. So I'm not an expert on acceptance and commitment therapy, but I know that it has a lot of similarities with mindfulness in the way that mindfulness is currently used in a non-secular way. So I believe that there are a lot of similarities. Especially everything related to self-compassion and self-acceptance and non-judgment. And there are some things also related to non-violent communication. So the tools were really inspired from different schools of thoughts, not yeah, I think that you would find a lot of similarities, even if we didn't intentionally use anything from ACT.
Thank you so much for that.
You're welcome.
Okay, great. So we have the contact information now on the screen. I'm going to take this opportunity. Oh, we have another question coming in. What should Sarah, can we take this other question?
If Natsnet is still there, but Caroline has already had to sign off. So if Sahar and Natsnet have the ability to stay for a few more minutes, yes, but otherwise we should probably wrap up.
Okay. Natsnet, do you have time to take another question?
Sure.
Okay. All right. This will be our last question for today. So Colin says, when talking about intersectionality as mentioned by Natsnet and Caroline, how do you incorporate this intersectionality approach into your work? Age, gender, and disability. Thanks for sharing your thoughts.
Mm-hmm. So thank you so much for this great question. It's quite important when we are kind of looking at any program that engages women to look at how women's diversity requires like a diverse approach. I think in the question Colin has mentioned about ability and disability, and like using the lens around diversity in terms of where we are, in terms of our economic status, in terms of our health status, in terms of meaning like HIV/AIDS, people living with HIV/AIDS, or sexual orientation and so on. So it's just kind of having like that moment when we are trying to understand the community that we are working with, and okay, what is the composition of the community that we are working with looking like, the women that we are engaging with, and what are the strategies that we can use in a way it is inclusive, like meaning that it allows diverse groups and diverse women to have the voice, to have the decision, as well as engage without causing any harm on those women. These are like some of the things that we could think about as we are designing, and then also making sure we have moments to check in with those diverse groups, how they're experiencing the programming, the intervention, and the different strategies, and then making sure what they're suggesting or what is coming out of that consultation is incorporated into the programming.
Great, Natsnet. Thank you so much. So again, thank you to all of our panelists. We're just getting a lot of positive feedback in the chat. It's great to have you be able to bring your expertise to this webinar. Thank you for taking the time. And thanks to all of the participants for joining. It's wonderful to see so many people interested in this topic. And finally, thanks to Sarah and to Laura for facilitating. I want to wish everybody a good morning, afternoon, or evening, wherever you are in the world.
Thank you so much, Jeanne, and thank you for putting together this great briefing note. We'll be circulating all the information on the Community of Practice and on the AoR website. And everyone take a great moment to do a little self-care and have a wonderful day. Thanks very much.
Thank you.
Thank you.